Good evening, everyone, and welcome to this event. It's a delight to be here. My name is Miriam Techmeyer. I'm a professor here at the School of Tropical Medicine and the co-director of the Institute of Resilient Health Systems that will be formally launched later in the year. Thank you very much for coming this evening in person. Thank you very much for coming online. We're really delighted you could join us for this event. This is a pretty special year for the School of Tropical Medicine as we celebrate our 125th anniversary. And many of our alumni, our staff, students, partners have played and continue to play a vital role in shaping global health. And first amongst that, I think, speaking as a hospital physician, is public health. Because public health is all about walking alongside the world's poor. Think about how it started. It started with advocating for clean water because poorest people were dying because of lack of clean water. And up to this day, as a public health physician, we have a duty of candor to speak out about avoidable and unfair differences in health. Things that we call health equity issues, things that are avoidable and that are unfair. And so I call on you all as LSTM partners, alumni, students, staff, to harness your inner public health physician, not just tonight, but in general, to speak out about avoidable and unfair differences in health. We have them right on our doorstep here in Liverpool. We have them in many of the countries we work in. I'm pleased to welcome three fantastic speakers tonight, an alumnus and two current members of staff. Professor Andrew Furber is the Regional Director for Public Health England in the North West and has long been at the forefront of public health policy. And I'm looking forward to you taking us on that journey today. Alongside Andrew, I'm pleased to welcome Nara, Tagiyeva-Milne, who is leads LSTM's MSc in International Public Health here. And David Ishola, who's a consultant epidemiologist and with Public Health Wales. And he's LSTM's clinical professional lead on public health education. So the public health trainees that come to us are under David, and I have the pleasure of having the office next door to him, and I can tell you he stays even later than I do, because I'm often there saying goodbye to him in the evenings late. And just to say that following the discussion tonight and everything, we'll be opening up the floor to some questions from those of you here in the room, so please just hold any questions that you might have. Thank you so much, and I'll hand over to Nara now.
Andrew, David, welcome to our conversation to explore your perspectives on health system resilience and resilient and responsive health systems, and particularly on the significance of that resilience in today's global context. And to start us off, I would like to ask for your thoughts on what truly makes a health system resilience in the world facing these diverse health challenges and threats. And we're speaking about those acute shocks to the system, such as pandemics, natural disasters, or, well, special military operations, as they call it, and also those chronic stressors, such as, again, one of the examples, antimicrobial resistance here, and an aging population. Please.
Thank you. Thank you very much for the invitation today. Really, really pleased to be here, and pleased that this has been set up as a conversation as well, because I think it's such an important topic, and I'm aware of the kind of wealth of experience in the room, and really looking forward to hearing from David as well, but also from your questions a little bit later on. Shocks to health systems are common. In fact, we think of them as infrequent events, but I think they're more common than we perhaps realise. And as I was kind of reading up in preparation for this, I was kind of reminded of the Ebola situation and some of the thinking that had and the analysis that had gone on after that. And there was a particular bit in the Lancet I quite liked that framed it quite well, that talked about resilient health systems needing 3 preconditions. So a global resilience network, so part of a broader system that itself is resilient. Having that kind of legal and policy framework, so obviously the international health regulations kind of help us with that, but just a kind of set of rules in which health systems operate. But then finally, the workforce, and that I think will be a theme that I'll return to on many occasions during this conversation. So if those are preconditions, what are some of the characteristics then? So again, this article, I think, framed it nicely in terms of 5 areas. So a resilient health system needs to be aware of what's coming, so needs to have that kind of surveillance, the kind of understanding of the epidemiology, knowing how to prepare adequately for the shocks that might come. A resilient health system needs to be diverse, including in its workforce actually, but in terms of the offer that it can make. If a health system is simply made up of one, let's say hospitals, acute hospitals, it's not going to be resilient because it needs to have that diversity of offer to deal with those challenges. It needs to be self-regulating, which I thought was an interesting one, because I think to contain those threats, to deal with them adequately, to make sure that the basic services that the system provides continues, it needs to be able to kind of manage that within a kind of self-regulating framework. It needs to be integrated, and just having an interesting conversation earlier with Miriam about that connection with communities, which again I think is really important, and I think a theme that I'll kind of come back to. But a health system isolated from everything else in society, I would suggest, is not a resilient one. And then finally, adaptive. So that ability to kind of transform quickly and change in response to that kind of acute shock or that acute threat. So that's just kind of some thoughts to frame it.
Thank you. So you're speaking this, David, anything to add to this?
Thank you, Nara. I think Andrew has provided a comprehensive response to that. I think potentially what one could add to that would be leadership to serve as, to coordinate all of those essential aspects that Andrew has talked about, leadership that is responsive and visionary and able to hold everything together. Thank you.
Okay, thank you, thanks. So you mentioned it's a global issues and global challenges and global problems. What do you think about in terms of the health resilience? Is there other differences in there between the regions, for example? Are there any unique factors that shape health resilience, for example, in low as versus to in high-income countries?
I suspect a lot of the themes will be the same, even though the context is different. So again, just to kind of go back to workforce, my time working in Nepal, a lot of that was spent on kind of training community health workers, training the government's primary healthcare workers within the district. And the government at the time was trying to build up that primary care infrastructure, and you go along to lovely new primary health centre and find there were no staff there. So that's clearly not a kind of resilient system. And in this country as well, people like David, who were out on the front line during the COVID response, did an amazing job. But I think we neglect our workforce at our peril. And I think coming out of the COVID pandemic, our staff and our teams have been through actually, quite traumatic events. People talk about, the Blitz spirit, which is true in a way. People did, carry on and do kind of amazing things in really difficult circumstances. But just as in the Blitz, actually, there was also, kind of fear and fatigue, and, people became ill as a result of their work, and therefore sort of caring for our workforce, whether you're in Malawi or Manchester, are equally important. And I think giving staff that time to recover, to reflect, those hot debriefs, the more structured kind of cold debriefs, the psychological support that goes alongside that, are all kind of really, really important.
Mm-hmm. Okay, thank you. Well, you started speaking about the crisis, and then if we're focused on the crisis, then what, in your opinion, are the most significant weaknesses in the health system here in the UK or, well, anywhere in the world that were exposed through by those crises? And we can look at, again, one example, so COVID you already made, maybe looking at that as an example.
Yeah, and again, I'd be really interested in David's thoughts on this, because, as I say, you were a really significant part of the response in the Northwest. I mean, I think first thing to say is that people responded in amazing ways, and I know there are people in this room, and the Liverpool School as well responded, both corporately and as kind of individuals. So, you know, that was amazing to put on my record, my thanks for all of that. And so my comments, my critique, if you like, is of the system, not a kind of individuals or teams. But I would kind of frame it in kind of two or three ways, really. I mean, I think that connection with community, you know, was very variable. There were kind of some really great examples of through the COVID-19 vaccination program, for example, where the NHS delivered that differently by partnering with local faith organisations, setting up clinics in mosques and so on. That worked really effectively, and areas that didn't do that and tried to kind of continue through more traditional ways of working didn't see the uptake that those other areas did. So I think those connections with community proved really important during the pandemic, and I think were a lesson that we kind of need to build on now when we're seeing cases of measles, when we're seeing that you know, a lot of the long-term condition management that we normally depend on has kind of dropped off, and you know, how do we kind of re-engage communities and gain people's confidence again in those kind of systems. And again, I think our workforce as well, to return to that again as a theme, I think it's become apparent that our workforce does not sufficiently reflect the communities that we serve. And I think for me that was a kind of a gap that was very evident during the response.
Thank you. Anything?
Yes, thank you. And in addition to that, I think we started from maybe a low base in terms of the entrenched inequalities that were present before the COVID pandemic came, which the pandemic then exposed. So it wasn't a surprise, ultimately, that the people who bore the brunt of it were the more deprived parts of the population. So I think one of the big learning is the need to focus a lot on that, and that links with the community engagement that Andrew was speaking about. And if we want to look beyond the UK, as you said, Nara, so looking at other parts of the world, I think if we think about a resilient health system as one that is, in effect, elastic, one that has an ability to adapt, to flex, in order to respond to those shocks that we're talking about. Obviously, in order to be able to accommodate shocks, there has to be a strong base. And I think in many of the lower and middle-income countries, that strong base was lacking at the beginning. However, they did have, some of them had more of the stronger community engagement, so in a way that also was helpful for them.
Thank you. Thanks. Well, I meant to ask about valuable lessons. You already mentioned to some extent, but there is the most important, importantly, not most important, but importantly for us, people in colleagues in LSTM who work internationally and in partnerships, is whether those lessons learned in one particular country or region, can they be applied to any other parts of the world? And from what you're saying, it is possible or not? But I want to hear your thoughts about that. And yeah.
Well, thank you. So, well, I think so. I think so. I think one of the things we've learned is the universality, really, of the human experience. a lot of the our health systems that we had presumed were very robust and very elastic, very resilient, actually, proved not to quite be the case. So it proved that we needed to learn from all around the world. We learned how connected the whole world is. And I believe that the world learned a lesson in terms of the, particularly one of the success stories, the vaccine program, which we went from no vaccine at all, from a completely new pathogen, to a vaccine in a year. In my opinion, part of the foundation for that was based on the experience with the global experience with the Ebola crisis. Because the Ebola crisis, there was a similar experience, well, not a new pathogen, but that's a different story in itself. But went from no vaccine to a vaccine in about 4 years, which was a massive jump at the time from what would have normally been maybe 10 years or more. So I think some of the learning about partnership, about working together, some of the basic technology from that experience was helpful in the COVID response. So I think that's one example of learning from a crisis in a lower middle-income country or lower middle-income region of the world, which proved to be valuable globally.
Thanks a lot. Anything to add?
Yeah, no, I'd agree absolutely. I think there are transferable lessons. I think they have to be done intelligently, and I think during the response I saw a lot of comparisons that were made that on the face of it looked reasonable, but when you started to scratch the surface you realized that there were contextual differences, maybe the differences in age structures of the population and other factors that meant it was slightly more nuanced perhaps than the authors were suggesting. But unquestionably I think there's some brilliant examples from around the world that we can learn from here in the UK, and maybe there are things that have come out of the UK's response that can inform what happens elsewhere. And I think that's one of the exciting things about being connected to LSTM, because I think that's exactly what you do. You have these tentacles around the world when you're kind of learning these things, and students come from all over the globe, and I think that's very exciting.
Thanks. Yeah. Well, when we discussed about the health system resilience, in order if we want to build a resilient health system, obviously we need effective strategies and strategies for adapting to those trends in health. And well, I would like to speak about them. You mentioned some of them, that collaborations, partnerships, that's one of them, and LSTM is very strong in that, exactly. And community engagement, you kind of allude to that as also. And well, there are a lot of vast topics. We can't cover everything, but being here in education, David and I myself involved in that, I would like to kind of speak about the role of education in building more resilient health systems. And well, the education mission is linked directly to LSTM mission to improve health outcomes among most disadvantaged across the globe, and our aim to equip our students to be able to have the knowledge, the skills, the competences to engage in the threat, working against the threats, and also, to be adapting to the changing circumstances. And you are one of the most exceptionally successful alumni, and one of the aims of LSTM mission of education as well, to lead our students to become future public health leaders. And we are extremely proud, take pride in your achievements as a leader in public health. So what are your perspectives on the role of education in this context and in general, and also reflecting on your experience here in LSTM? And also would like to hear your insights about the role of education which should be evolved and expanded in the future.
Thank you. You're far too kind. But no, seriously, I mean, the 3 months I spent here doing the DTM&H, it was without question the best course I've ever done. And part of that was the content and the teaching, which was fabulous and the topics were fascinating, but a big part of it were the student cadre, meeting people from around the world, hearing about their stories and experiences was just absolutely amazing, and still in touch with some of them now all these years later. But I think education, healthcare is fundamentally a people business, in my opinion. People talk about it being driven by data and how will AI change all of it, and we'll talk about technology a little bit later perhaps, but I still firmly believe fundamentally healthcare is a people business, and therefore the education of the workforce is fundamentally important. The NHS, for example, spends more on its people than anything else, more than it spends on its buildings and medicines and anything else. The biggest cost to the NHS, the biggest asset to the NHS is its people, and therefore it's astonishing in a way that after being in existence for 75 years, only just now has it come up with a workforce plan. But at least it's come up with a plan now, and if it delivers it, then that will be a good thing. And the plan talks about the need for education and that continuing education, actually, so that people through their careers can evolve, understand some of the new technologies coming through, flex in terms of what they're doing, incorporate preventative interventions within their work. So I think it's the education of the workforce fundamentally important.
Yes, exactly. To be at the breast of advancements in treatment modalities, in the modern technologies, and also in policies, to be able to continue, as you said, and adapt to the future threats and changes. David, anything about?
Oh, thank you. Yes, I totally agree with that. I mean, obviously, an additional, perhaps, aspect is education in terms of research, training, and capacity building, which, of course, there are a lot of global leaders in research leadership and research training in the room here, and many of the people who have passed through this institution, such as Andrew, such as many others around the world, played leading roles in the response to COVID, and will play lead roles in response to future shocks. So definitely education at all levels is a crucial part of resilience in health systems.
Yeah, and also adding to the capacity, again, workforce capacity, as we already mentioned, it's all linked together. Okay, thank you. What other strategies you could think of are very important for for future health system resilient health systems?
Can I throw in something else? Perhaps in answer to one of your earlier questions about some of the kind of learning from the Global South, because I think one of the things that I was just kind of reflecting on today was climate change. Actually, the first day of the DTM&H course, whoever was introducing it said, "Welcome to Liverpool. The rainy season here starts on the 1st of September and ends on the 31st of August." And today is probably evidence of that. But climate change is going to be a very significant challenge to resilient health systems. And I think there's some real learning from the Global South about how healthcare can be delivered in kind of lower carbon ways with lower impact on the environment. And I think one of my roles is being the Senior Responsible Officer for the Greener NHS programme in the Northwest, and colleagues are doing some amazing things around reducing single-use plastic, reducing carbon output, better use of some of the anaesthetic gases, which are really bad for the climate. But I think there's also climate adaptation that's needed, because we are going to see more adverse weather events. In the Global South, they're going to experience some very significant temperature rises, which obviously are going to be challenges for dealing with health. It's driving migration. And again, back to the workforce, how do you retain that healthcare workforce that's needed for a resilient health system? So I think climate change, again, as a factor within resilient health systems, I think is really important.
And what are the strategies in relation to that, climate change or anything else, technology, for example, if we bring in that, you mentioned those, how do you see the role of, it is growing, the role of technology growing everywhere and in any aspect. In terms of their resilience, what could you say?
Yeah, no, I think it's really important. I realised the other day, which is a bit of a shock to me, I have to say, that it was 40 years ago this year that I went to medical school. I really can't believe it's that long, but apparently it is. And when I went to the library at Newcastle Medical School, and you wanted to find a journal article, you used to have to get something called Index Medicus, and you'd thumb through it and you'd find the keywords, and then you'd scurry off and find the journal. And then towards the end of my time there, they got the first 2 computers in the library, and there was a big queue of people to use these computers to find their journal articles and so on. And now, you know, you just couldn't imagine, I couldn't imagine practicing public health without information technology and the use of computers. And I suspect in 40 years' time, artificial intelligence will have transformed it again. So I think I still hold to the fact that it's fundamentally a people business, but I think we now have technology as a tool. And I think we saw that during COVID, actually. I think how we use that to mitigate transmission through remote care, through home testing, through some of the modelling, the machine learning, through some of the staff education, supporting staff in terms of some of the new things that they needed to do. Remote monitoring, telepharmacy, AI-supported decision-making increasingly common. So I think there's lots of ways in which technology can support health systems during that acute shock, as well as being part of the infrastructure that's needed to be resilient.
Sure. Technology is very important in education, of course, because we're trying to apply innovative approaches to education programs, training programs, those simulations, those with scenario-based, we're integrated, real life, almost real life experiences and diverse perspectives. So that's very important. And at the same time, on the other hand, what about we hope that technology, we're seeing technology helping to build resilient and improve the health systems. At the same time, there are some challenges which can create. For example, speaking about our health force, will they need to be adapting to their work in that new, more technology-led system, and how does that will work?
Thank you, Andrew. Well, I think that perhaps goes back to education, in the sense that more training and new ways of training are needed. And I think that applies to everyone. Those who deliver the training themselves need to be trained and to learn and to be adaptive. And I think another benefit of technology is that, we spoke earlier about partnerships. There's a degree to which the new technologies have also made partnerships easier. The kind of event that we are having here today, probably 3 or 4 years ago, probably we would not do this. Now we can connect a little bit more easily, which from the horrors of the COVID pandemic, one of the perhaps learning that has emerged is the new ways of communicating. And also technologies around, I mentioned earlier, vaccine technologies, diagnostic technologies, therapeutic technologies. So I think technology definitely is going to be key. Well, you mentioned about some of the potential drawbacks. Everyone of us is aware of the issues with AI. And again, here, there's a lot of leadership on a response to AI and all the anxieties around it. And I think it's incumbent on us to make sure that we engage with that and learn how to make the best of it and mitigate the potential problems. And partners such as UKHSA are providing global leadership around that. And I think it's an opportunity. So I prefer to see all of those as opportunities rather than potential hindrances.
Probably one of the other challenges, just thinking of Miriam's challenge about inequalities and how we ought to be advocating for that, both in terms of our workforce. So if we use computer-based learning, that's fine for most of us that have a desk and a computer and work hours that mean that we can access that. But the lowest paid in the health and care system often don't have access to a computer, don't sit at a desk, don't work the sort of hours that enable them to engage in that. So you're creating widening that kind of inequality between those that have access to that sort of e-learning and those that don't. And similarly for those that we're here to serve in our communities, again, there's a kind of digital divide of those who do have access to technology that enables them to access things in a way that others don't. So always remembering that kind of inequality.
Yeah, thank you. Yeah, in terms of technology, again, I think you and I have discussed about manufacturing, help with the vaccines. Again, we did discuss that, but again, it brings us inequality, whether those are distributed equally and where the products are going to. Yes, that's another issue. What are other potential strategies to make, speaking about challenges, the challenges can be, some of the challenges they are maybe typical for across the globe. Some of them may be unique to specific countries or regions. I'm myself originally from Azerbaijan, and as Azerbaijan and any other post-Soviet Union republics face a range of challenges. Some of them are typical for any low middle income countries, others are unique, and among typical will be underfunded and outdated healthcare infrastructure, which leads to the limited access to quality care for many citizens. Other one, a transition from the centralized to decentralized system, which leads to disruption and disparities in the health allocation, resources allocation and services. And the unique is that Soviet era model of care, which was primarily focused on curative rather than preventive and care, and obviously there are health inequalities and the straight overs. So that's kind of unique for what in terms of again, coming to challenges and maybe technology, maybe others. So what are the unique and what are specific or what are typical for, let's say if we speak about the UK, and then we can talk about other places in the world.
Well, one of the challenges that we're facing at the moment in the UK is around finance. I don't expect that's unique to us, actually. I suspect that's a kind of global challenge. But having a resilient health system clearly needs stable financing and financial planning and that ability to procure things rapidly, to make sure that staff get paid and, are looked after properly. So I think that's a challenge for health economies around the world, I suspect at the moment, but particularly in the UK, where the average healthcare inflation is something like 4% a year, but the funding has been kind of less than that. So you've got a gap which is now kind of manifesting itself in terms of some of the pressures that you'll be reading about in your newspapers every day. So I think finance as an underpinning part of a resilient health system really important.
Okay, thank you. That again, but we're moving forward, and there is hope. And towards the end, I would like to hear your thoughts on your vision, or ask you about your vision for the future. And having a chat with you before the event, and obviously we had discussions about. I know you both are feel positive. So with looking ahead, and what do you see? How do you see let's say the role, why do you think the global health, there is a future for global public health? What gives you that hope for the future of global public health? And also that we will manage to build the resilience to address any coming threats in the future?
Maybe I'll start, and David, you follow on. But I think there's two things for me. I think firstly, that growing understanding that health is a human right. I think that kind of rights-based approach to health is really important, and I think as people understand that, again, one of the kind of light bulb moments for me when I worked in Nepal, it was part of a sort of broader community health program, and for me, the most inspiring bit of that program was what was called non-formal education. So basically teaching particularly the women of the village to read and write in their own language. And I remember going to the first of one of those classes, and the women, they just wouldn't even make eye contact, they wouldn't say anything, they just looked at the floor. By the end of the 10-week course, they were banging the desk and saying, you know, why are there no medicines in my health post? Why is the health worker not turning up? And I think that sense that health is a human right and that people should be demanding that kind of basic level of health it gives me hope that will kind of drive systems. I think the other thing that gives me hope is that you just meet so many passionate people who are so dedicated to providing that health for communities, whether it be in this country or overseas. One of my favourite overseas examples was from Maharashtra. Mispronounced, haven't I? Maharashtra. The JAMKED project, I think it was called, and again, passionate people there working at community level, building up something really transformational across actually quite a large population. So I think that combination of people demanding health as a human right and passionate people that are there driving forward the system gives me hope.
Yeah, thanks. And to add to that, your comment about the community education, that's a part of the education again, and that's a really important part. It's not just training the professionals, healthcare workers for the future, but also communities, the loyal people who are, taking that as their own responsibility. They're taking health in their hands. Thank you for that.
Yes, I think you both hit the nail on the head. It's the people. I think as a people, despite all the negativity, there's always hope in the way that as a people, and I mean globally, people have always risen to the challenge. We've seen it in all across the world, and I think that gives hope.
Yeah, exactly. And the collaboration, which you mentioned, started speaking about, that's another part, isn't it? We need to work together in partnerships, and then building those relationships, which again gives that hope. Yeah, thanks a lot. I think, thank you very much for that insightful conversation. I think we can now open floor to the audience answers and questions. Questions and answers, please. Yes.
You said that the workforce did not reflect the community it serves. What needs to change, please?
Yeah, that is a really good question. I think there's a number of things that need to change. I think my view is that there's kind of structural racism within. I can only talk about the kind of English NHS here. Others in the room will be able to comment as to whether this is a kind of broader issue. But I think, you know, there is structural racism in the NHS about how we train and recruit people, how we promote people, and you know, even things like recording of an ethnicity data in terms of some of our services is very poor. So we don't know actually how we're providing services to our diverse communities across the Northwest and across the country more broadly. There's a whole range of things kind of going on to try and address that. Black internship programs, for example, that we're hoping to participate in, getting people who are at medical school or training in health services to come in to get some kind of work experience. You know, good recruitment practices, making sure that equality, diversity are featured as part of those interviews and recruitment processes. You know, a whole range of things that we need to be doing, but I think we're still on a kind of learning journey. Do you have any thoughts?
No, I don't think I have enough experience.
Right, but good question.
Yeah, but I was interested to find out what you think we need to put in place to eradicate the problem.
Yeah.
And it's again about education, isn't it?
Yeah.
That's very much. Yeah. Mm-hmm.
Yes, and I think that's all absolutely right. And I think another aspect of it is the well-recognized issues with gender imbalance. I was reading recently reading an analysis from the Office of National Statistics a few years ago, when the concerns about AI first began and the potential impact of AI on the workforce. And the analysis suggested that perhaps some of the jobs that are most likely, well, that's, predictions may or may not happen. Some of the jobs that are most likely to be affected or to be lost to AI are jobs that are mostly held by women and by the more deprived parts of the population. So there's a risk that advance, that positive advance, might further worsen inequalities. So there's a need. We have to be vigilant and make sure that we are aware of that, and make sure we take positive steps to make sure that we mitigate that risk.
Really good point. If you look at the lowest paid roles in the health and care system, predominantly women.
Thank you, all three of you, for fabulous conversation. I found myself writing lots of things down, but I have two questions, if I may. One is, if you could reflect a little bit on the importance of how challenges are phrased or framed. Because I heard you say, David, that it was a marvelous thing that we got to a vaccine. But I also think that I heard Mariana Mazzucato at UCL say the big problem with the way we framed the vaccine problem is that we said we needed a vaccine, whereas actually we needed to vaccinate the world. And I think there's a fundamental difference that we often miss. And the other one that I heard here was, again, climate change. I think climate change is the wrong framing. This is a climate crisis. I think some of that framing, so I'd love to hear what I sometimes feel like we need to think much more urgently about what the ultimate thing is we're aiming for. So that was just one reflection. And the other, if I may, was right where you began, Andrew. You talked about international supportive networks. And when I think about LSTM, its partnerships, its research partnerships, its alumni, if you could say a little bit more about how does that supportive international network that seems to be a precondition for resilient health systems, how can that really be, what's in it, and how can it really be strengthened? Sorry, I took a prerogative, two questions. Sorry.
Two really good questions. I mean, the first one on the framing, again, I think that's a brilliant point. There's an organisation, I think, called the Frameworks Institute that does exactly this kind of thinking. It looks at problems and thinks, well, how can you frame it in a way that actually kind of makes more sense or helps you kind of realise the goal that you're looking to try and achieve? And you've given two really good examples there. In terms of the international networks, again, it's a great question, but a difficult one to answer. I mean, it was very real during the pandemic. I had actually, I don't think it was a colleague from the Liverpool School, a colleague from another network that contacted me from Australia, looking for some of the protocols that we'd developed, which we were able to kind of share with her. And there was lots of that going on, kind of informally, almost. Because of personal contacts, but how would you kind of formalise that? How would you, and I think again LSTM have a great opportunity through the kind of alumni and these sort of events to kind of connect people, reconnect people, create that kind of forum for sharing some of that practice. Anything to add?
Thank you very much, and I'm sure Nara will have a perspective on this as well. I mean, absolutely, we need to be very careful with our phrasing, our terminology. I think we need to make sure that our terminology is respectful of diversity, respectful to it can reach out to all parts of the population, I think it's something that we need to work on a lot more.
But it's we're getting there, and the more diverse students, population, and colleagues we have, more likely we will do the right thing. And in terms of the communication, you mentioned these events. That's very important to, again, share the values, the missions, and have discussion about that, and discussion not on local, more global, more national and international level. And I think that will bring us all together again, and that will bring us to become more resilient and more successful in any other initiatives. Thank you. Any other questions? Yes, yes, please.
Thank you for the conversation today. I just have a question about, you touched about it, Andrew, about digital literacy and sort of our patient population who really needed having access to simple things as, you know, computers or the access to internet, and also understanding the resources that are being created and provided by the NHS. Because I find from a shop floor level, I work as a medical registrar in a hospital, and to be honest with you, the patients that come to us, their knowledge of their health isn't necessarily gained from all these resources that the NHS has put a lot of money into, you know, developing things on the NHS websites, all these apps that you have on the phones, maybe even you could say sort of online appointments and things that a lot of GP practices are pushing out. But in reality, you know, is an 80-year-old person living by themselves, do they have a smartphone? Can they access the app? Can they, you know, in time connect with their GP? So I was wondering whether there's thought in the NHS to still retain some of the quite classical traditional model of patients coming in person to A&Es, to GP practice, and simply just needing to speak to somebody about their problem and still being able to access healthcare. Otherwise, these people will simply be excluded, and they will present very late, and they will be very costly to the health system.
Again, a really, really good point, which I entirely agree. And I think the trick here is to use technology, use the apps to deal with probably the majority of people that can access these things, but don't then disinvest in the kind of more traditional ways of engaging with people, making sure that people are able to get in touch and so on. So I agree with you absolutely. I thought you were going to say that where people are getting their information from are kind of, for want of a better word, alternative sources. So they've read something on Facebook and they think this is therefore, you know, true, and what they've got and so on. So I think that's another challenge. How do you deal with that kind of misinformation that's out there so widely on social media, in many ways presented in a more attractive way and accessible way than we do through NHS apps and so on. But yeah, the digital divide, a real challenge.
Thank you. David and Andrew, do you have any examples of overseas learning that you bring to bear on your current roles in the UK?
Yes. Thank you very much for that. I think it's the down-to-earth community engagement is one of the key lessons that I've learned from some of the low and middle income communities, particularly in West Africa, where I've had the privilege of working. There is still, I think down to earth is probably, I don't want to say traditional, or because, you know, all that terminology, being careful about words can sound maybe, you know, a little bit negative, but it's just an element of complexity, yet simple, respectful element that is there that does help speaking with people, having that personal connection. A lot of value is still placed on some of those human values, I would say. It's tempting to say simple values, but I would say human values. So the challenge, though, is that there is a risk of some of that being lost progressively. So communities around the world are facing that common challenge as well, to try to make sure that we don't lose the humanness that binds us together. If I may, one other thing is that there's a growing recognition, in a way a humility, I would say, a growing recognition of the challenges and of the need, the hunger to learn and to grow and to develop. And that's something that I've found very valuable. Thank you.
It's a great question. There are probably lots and lots of things, but the one thing that comes to mind immediately is that cultural understanding of health and illness. And the example I would give, again, from when I was in Nepal, I had the privilege of working alongside a couple of anthropologists. I think we need more anthropologists. NHS needs more anthropologists, for sure. But I was working on part of the national HIV program in Nepal, and it was a low prevalence country, and there was a lot of concern because a lot of Nepali men were migrating to some of the northern Indian cities and where the HIV prevalence was higher, and there was concern that the infection would be imported into the country, and so there was a lot of campaigns at the time, and I remember one in particular that had, it sounds farcical when I describe it now, but it had a picture of a condom that was kind of dressed as a sort of knight in shining armour sort of thing with a sword that was kind of fighting off this kind of HIV virus, and that kind of whole war schema is something that's understandable to us in a kind of Western construct. We think about fighting cancer, winning the battle, that sort of thing. But for a Hindu culture, that was just something that wasn't kind of understandable at all. It was more about sort of hot and cold things and a different way of thinking about health and illness. So that's something I kind of keep with me in my practice now, thinking, have we got the kind of, goes back to that kind of framing question, have we got that right cultural understanding, have we got that right framing for what we're doing here? So that's something I personally learned.
I want to ask a slightly different question. We've talked a lot about health inequalities, and I think we dance around health inequalities. It's about poverty. It's about inequalities in wealth. What do you think is the health leader's role in speaking about this in the honest way? Because I think we've sanitised it, calling it health inequalities, and we've actually forgot to say what it's really about. It's about wealth and the distribution of it. So what do you think our role is as health leaders in outing the language in a way that actually is saying it as it is?
Great question, Anne. And you're absolutely right. And Michael Marmot, I think, does this very well, and increasingly so. I think from his Whitehall studies, he's made these observations. But as the years go on, I hear him increasingly saying that, this is due to people's social circumstances. It's the fact that their income isn't sufficient to support good health, and he's absolutely right. And indeed, Matt Ashton, the DPH from this great city, was on the Today programme the other day with his Health of Liverpool in 2040 programme, and he was asked that very question, is this due to poverty? And he said absolutely yes. So I think we do need to say that, because, as you say, it's absolutely true that these health inequalities don't appear in a vacuum. They appear in the context of the socioeconomic circumstances in which people find themselves.
We also have a question here online from Noor. She says she agrees on poor ethnicity data recording, and this is a particular issue in capturing inclusion health groups, including homelessness, asylum seekers, migrants. How can we make sure our resilience in this area, where these population groups are not missed in our analysis, policymakers, in addition to the workforce you mentioned?
Yeah, a really good question, bringing out another dimension to that in terms of those multiply disadvantaged groups with the homeless, asylum seekers and so on. We've just kind of kicked off a piece of work in the Northwest looking at how we can kind of record that better. And it's extraordinary in the number of challenges that you come across that, and I think they're kind of more perceived sensitivities from healthcare workers that, clearly want to maintain a good relationship with their client or their patient and feel uncomfortable about asking some of those questions about people's circumstances. But if we don't find a way of asking, if we don't find a way of recording that information, then those inequalities are never going to be recognised and therefore addressed. So we're doing a bit of work to see how we can populate some of that stuff automatically through other kind of sources of information, but also provide support for healthcare workers to find ways of asking those questions in a sensitive and a way that they would feel kind of comfortable with.
It also relates to the training, isn't it? Continuous training of healthcare professionals, people in the medicine and health, to make sure they are they're adapting to the changes in the population, changes in the threats, and changes in the coming challenges. Yeah.
So I have a short question. You mentioned structural racism within the NHS. And I was an NHS worker for many, many years. But I also wonder whether on another level, we have it in our partnerships and where we accept or we endorse good practice from, that maybe if it comes from a high-income country, it's given more respect and quickly maybe taken ownership of, where if it comes from a lesser voice or one that's perceived a lesser voice, we sort of push it away, think, oh, no, no. I just wondered what you thought about this.
I'm sure that you're absolutely right. People go across the United States, don't they, for training and to kind of learn what's happening there, and that's one of the most unequal health systems in the world. And you know, we should be looking to the global south for, you know, some of those real examples of community engagement, of kind of building up from the bottom, making much better use of community services and primary care, rather than from the sort of biomedical model that's kind of centered around hospitals and acute care, which of course has its role and its place, but in terms of a resilient health system, hasn't got those foundations, it's not going to be resilient. So I think you're right.
Yes, I will take on the usual optimistic view about it, and hope that things are increasing, we are learning. I'll give an example. During the COVID crisis, we had the situation with the discovery of the Omicron variant, which was from the global south, and you know, there was and everything, all the complexities around that. And I think as a collective, as a people, as a species, I'm hopeful that we are learning, and that we are on the pathway to getting better in that respect.
Thank you. Thank you, Andrew and Nara and David. It's been a wonderful evening. I just want to say that my one key take about today's session, including the session of this morning, has been that resilient health systems need to be people-centered. And this people-centeredness means a lot to many of us public health researchers and practitioners. And actually, definitions can be very nuanced. People can go from, you know, being people's needs, others will go on values and behaviors and all of that. I just want to understand what your take on this, on what people-centered resilient health systems could look like. And then the second bit of my question goes on the aspect of community engagement. And it's generally been seen as a nice strategy to foster people-centeredness in health systems. But the trouble is that in the details of what actually works in community engagement programs that actually fosters people-centeredness in health systems. What is really your take on that? Thank you.
Yes. I think you framed it really well in terms of people-centered, resilient health systems. I think that's a nice way of thinking about it, and I agree entirely. In terms of what works, in terms of effective community engagement, there's probably others here that have a better understanding of that than me. But I think even just kind of thinking about it and starting with that question, you know, how can I make sure that my community is part of this health system, is a good start. And I think if people go into it with that kind of open mind, asking the question, trying to do the right thing, that provides the foundations for doing it. But I don't know, others will have more experience of what works.
Well, I think, yes, I agree with Miriam, that is an easy one. Well, I think it's interesting. Nara and I have been leading a module in the past few weeks on health systems and with MPH students. And we've been using the WHO 6 building blocks model as, sort of one of our teaching aids. And we did a critique on it. And obviously one of the strongest critiques of it is that it's not people-centered. And some scholars have redrawn the model to put people right at the center. So we had an interesting session of asking the students to kind of share their thoughts on something similar to that question. There were a lot of interesting feedback, but one of them is that I think we have to get better at asking questions, at being open, at being humble, and asking people what matters, what's important to them. I remember several years ago asking a colleague about, sort of PhD student level, asking a colleague about sort of different modes of research, and asking specifically about surveys. And I've not quite forgotten some of the terminology he used to sort of dismiss surveys as, that's just, for marketers, and, it's not important. But, we need to understand what's important to people, feel the pulse of the community, and incorporate it more into our educational programs.
Yeah, and do more research. Today's morning session demonstrated the wealth of research we have doing here in LSTM, and that's contributes that knowledge and understanding.
Thank you very much for a really nice conversation. Andrew, I think you said you did the DTM&H program a few years ago, and of course that's a very intense program. It probably was then and is now, and I just wondered if there's one thing that you remember really taking away from the DTM&H.
That mosquitoes are fascinating. Identifying the different types, understanding their life cycles and how they transmit disease, just extraordinary. So I really enjoyed that, yeah.
And may I dare to add something that I've learned, actually. I think a comment that Andrew made near the beginning, which really registered with me, was about how you are still in touch with some of the colleagues from way back then. So I think at least what I've gained is that one of the benefits from that is the networking, the connection, and so that, I think that's goes back to the notion of people-centeredness. So despite all the knowledge, which gets outdated, theories get outdated, but that human connection, the networking, I think is key.
Thank you. Thanks for that. And then we'll finish on this positive note. Thanks to you both and to the audience for your interesting questions. And we try to cover this. We managed to cover some aspects of the health system resilience. Obviously, it's a vast and multifaceted topic, so can be covered, but it's lots to explore, and so I would like to encourage you to have continued conversation maybe during the reception today, and also we'll be delighted to have you join us again here, Andrew, for the next round of events and conversations. Okay, thank you so much. Thanks.
Thank you.